Uh, Very good evening to all of you. We are here on the fag end of the second week of the Rainbow series. This is the third talk of the week. We are ending with the Indigo week. So we are in the middle of the, almost at the middle of the complete web series. So I invite all of you for this meeting. We have eminent speaker, Dr. Rajesh Karuvattil. Sir is the pediatric neurologist of BMH Hospital. And this session will be chaired by none other than our Dr. Mohammed sir. Sir was the former HOD of pediatric neurology inside SAT Hospital. Sir is our past IAP president. Sir is presently the EB member of CIAP. So I invite Punju sir and Dr. Rajesh sir for this to this meeting. I can see a lot of senior members, Venkateshan sir, Shashidharan sir, Shaji sir, many others also. Invite all of you for this meeting. So we'll directly go to the session. I invite Dr. Mohammaduni sir to chair the session. Over to you, Punju sir.
Okay. Okay. Good evening to all. I'm happy to chair this session organized by Calicut IAP because in the name of Rainbow, all of you will be remembering our Vibjior and the Maravilla film. Okay, so I'm very happy to chair this session. And again, our Dr. Rajesh, our very, very active and enthusiastic IAP Pediatric Neurology Kerala chapter secretary, because last year he was able to procure the best specialty chapter award from Kerala, and actually only because of his report, the national IAP, actually IAP Neurology chapter got the award. It was because of his reporting only. So that means I must congratulate Dr. Rajesh for doing an excellent work in the IAP as well as in the Pediatric Neurology chapter. And regarding the topic, actually he has selected a very, very dynamic topic, that is the diversity of epilepsy and the spectrum to precision medicine. Some of you may be thinking, why this precision medicine? Because we all know that when we have a pneumococcal meningitis or a meningococcal meningitis, we have a gadget, and you give meningococcal meningitis, you give even a single dose of crystalline penicillin, and the infection will be controlled. But when it comes to epilepsy, we don't have a shot like that. And what we use is the anti-epileptic drugs. And these anti-epileptic drugs just give you a time window, because we all give this treatment for 2 years, 3 years, like that, so that by the time that the process gets subsides, and we have a statistical analysis that when you are giving, your patient is free of seizures, the chances of recurrence is less than 30%. So just by our all the anticonvulsants, including the newer anticonvulsants, does not treat the cause, but it just treat the symptom. But when it comes to precision medicine, means we are looking for a drug or a specific treatment which will be able to cut short the epileptogenic process, so that the process is stopped and the seizures are controlled. And that means there is a cure for the epilepsy, because till now we don't, that is why we always speak about that we don't have a cure, but we are just controlling the seizure. That is the current treatment. But nowadays there are certain epilepsies are emerging and treatment processes are emerging where the precision treatment is there, whereby we can just annihilate the seizure process. Anyway, I think Dr. Rajesh will be highlighting on cases, and because I think because all of us are more interested nowadays in cases, so I think he'll be highlighting those things, plus the way to the precision medicine in epilepsy. I think without taking much time, I invite Dr. Rajesh. He is the consultant pediatric neurologist in the Baby Memorial Hospital, Calicut, and I think he is an upcoming, our established pediatric neurologist already. I welcome him once again to deliver his talk on pediatric epilepsy diversity. Okay.
Thank you, Kunju sir, for that nice introduction. Our President Ashraf sir has joined. I invite Ashraf sir for the presidential address before we go to the proper talk. Ashraf sir.
Thank you, Kunju sir, for accepting our invitation. I was little late because of some technical issue. We are straight away going to the Dr. Rajesh. Dr. Rajesh.
Thank you. Thank you, IAP Calicut, for giving me this opportunity to talk today. And I thank Dr. Kunju sir for the very kind words, and he has been a mentor to me. And without his guidance and support and activities, along with Ananda Keshavan sir and the consultants from Medical College Trivandrum, we wouldn't have got the recognition of the best subspecialty branch. So thank you, Kunju sir, for the support, and Ananda Keshavan sir, and also support all the senior, also acknowledge and thank all my teachers in the group from IMCH and other friends and colleagues who have supported me. So we'll get into the topic now. So the topic for today is the pediatric epilepsy. We'll be looking in two parts. One is the diversity of etiology underlying the epilepsy or seizure, and secondly, we go through the drugs. So we'll look at so this is our objective today. So we look at the classification of seizures, and we look at diverse etiology with some illustrative cases, and we will say a word about EEG, and we'll also then come to the second part, which is about the treatment, and that's a title, broad spectrum to go into precision medicine. So we'll go through a general framework for choosing appropriate anti-epileptic drug, but we'll not be covering in detail about the individual drugs, and also how the technology has helped us from moving from a broad spectrum to more precision medicine, which we'll talk about in the upcoming slides. So this is targeted at a pediatrician level, as was the focus of this talk. So coming to the definitions, seizure is one of the most common pediatric neurologic disorder encountered in practice of any pediatrician. And by definition, it's a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. So epilepsy is again a common disorder. It's about 4 to 5 per 1,000, and in developing countries like India, we have about 8 to 10 per 1,000. And by definition, epilepsy is at least 2 unprovoked seizures occurring greater than 24 hours apart, or 1 unprovoked seizure with the probability of further seizure similar to the general recurrence risk of at least 60%, which after 2 unprovoked seizure, or a diagnosis of an epilepsy syndrome. Now, this is the ILA, International League Against Epilepsy 2017 classification. So the seizure types are classified based on the onset. So we have this generalized onset, which many of us are familiar with. So we have, which could be motor, tonic-clonic, clonic, tonic, myoclonic, atonic, and epileptic spasms, or it could be non-motor, such as an absence seizure. And then this part, we have this focal onset seizure. So they are classified based on whether there is awareness, whether the child is aware during the seizure, or whether there is an impaired awareness. And again, that could have motor onset, such as automatisms and all that things, what you can see on the slide, and non-motor onset, which is like autonomic symptoms, behavior arrest, emotional, sensory symptoms, etc. And the term secondary generalized is now changed to focal to bilateral tonic-clonic. So secondary generalized can confuse people. So the ILA is recommending this terminology, focal to bilateral tonic-clonic. And the third group is an unknown onset, where we have motor onset and non-motor onset. So it's difficult to classify in the beginning whether it's focal or generalized. So we put that in the unclassified group. So this is the change in the terminology. So the old terminology used to be partial. Now we call it focal. Generalized, same. Simple seizure, we call it with awareness. Focal seizure with awareness. Complex, we call it with impaired awareness. And as I mentioned, secondary generalization is focal to bilateral tonic-clonic. And this is the International League Against Epilepsy classification of seizure. So the first part is the seizure type. So what is a seizure type? And then epilepsy, so you can classify by seizure types. It could be focal onset, generalized, both generalized and focal, or it can be unknown onset. And here again, at seizure type, we are looking at the etiology. So the etiology could be genetic cause, could be a structural cause, such as development of cortical malformations like lissencephaly, pachydiarrhea, polymicrogyria, etc. It could be a metabolic cause, or it could be underlying immune disorder, and it could be underlying infection, and sometimes the cause is unknown. So based on the seizure type, you'll try to see if it fits into an epilepsy syndrome, such as childhood absence epilepsy or West syndrome, etc. And then you look at each step, you're trying to find if there is an etiology. And along with on one side, you're looking at this etiology, but other side is also important because we're dealing with the child and the family. We also look at the comorbidities and address that appropriately as well. Now, the diagnosis is, again, it's difficult because it relies a lot on history. And so it's like a jigsaw puzzle. So good history is very important. And witness description will actually really help to narrow down the diagnosis. So if we can speak to the teacher or the caretaker, whoever is witness a seizure, it would really help. Past medical history is important, and examination will also be clue. So we put all this together first. So we have by this we have a pre-test probability of how likely is this going to be a seizure. So it is not the EEG which decides whether it's an epileptic seizure. So we have a pre-test probability before going into the investigations and EEG. So in this child, examination can give some clues. We can see the adenoma sebaceum, ash leaf macule, so it's child with tuberous sclerosis. So neurocutaneous syndromes are one of the common ones causing epilepsy. This child, we have capillary spots, capillary macules, and axillary freckling in neurofibromatosis type 1. And the cause could be genetic, such as the child on the left. This child presented with myoclonic seizure, had a large head, was weighing about, at 9 months, weighing about 13 kgs, had macrosomia. The child had confirmed Soto's syndrome. And these two twins unfortunately got the same condition. They're known as happy puppet or Angelman's. So they both have epilepsy and along with other behavioral problems. Now, what are the investigations? So we have the routine investigations. So any child with seizure will go through the usual calcium, magnesium, electrolytes, glucose, CPC, and other things may help with relating to depending on the clinical scenario. And imaging is useful. Acute situation, you go for CT, such as trauma, intracranial bleed. If it's an unstable child, if you want to do a LP in an unstable child, then you may go for an acute CT to rule out any acute contraindications. Otherwise, MRI brain is the preferred option, and metabolic or other investigations as felt appropriate. Now, this is a big catch that the studies have shown that the diagnosis, as I mentioned, relies a lot on history. So about 30% of patients seen at epilepsy center for refractory seizures actually do not have epilepsy. And why is there a misdiagnosis? So what they normally found is overinterpretation of normal EEG, which is more harmful than underreporting. There are temporal non-specific fluctuations which are often overread. And so it's important to see as a clinician to see if the EEG report correlates with the clinical picture. And the diagnosis often is psychogenic, non-epileptic seizures, syncope, cardiac syncope, miscellaneous diagnosis, unexplained, etc. The importance of syncope again was highlighted in our IMCH alumni group, whether it's a child with bradycardia, exercise-induced syncopal episodes. So it's must that in any syncope, particularly with motor components, we do at least an ECG as a minimum to rule out long QTC or other rhythm abnormalities. So what is EEG? So EEG is one of the cornerstone in diagnosis of epilepsy. EEG consists of a background activity and a paroxysmal activity. So abnormal, so EEG can be abnormal either because of the background activity, which again, it's an awake stage is different. In sleep stage, according to sleep stage 1, stage 2, or deep sleep, it's different. Or there is a paroxysmal activity which pops out from the background. So that is the epileptiform activity. Epileptiform activity can be spikes, sharp waves, or spike and wave discharges based on the morphology. Now there's a pitfalls in EEG because EEG lacks sensitivity. Even normal people, it can be normal even with those children with definite epilepsy. So you cannot rely on EEG in that way. It lacks specificity also. About 2 to 5% of normal children will have epileptiform EEG abnormalities. That doesn't mean they have epilepsy. And it is also liable for misinterpretation. Sensitivity of EEG, when you take an awake EEG, it's said to be about 50% times. There's a chance of getting an abnormal EEG even in an epileptic child. If you take a sleep EEG, you can increase the sensitivity to about 80%. And sometimes you do 3 or 4 EEGs and then you can increase up to 92%. So if you are doing only one EEG, it would be ideal if you get a sleep EEG as well. And sometimes the reason EEG can be normal is if the epileptogenic zone where the seizure is starting, if it is small or deep, then you may miss it on a scalp EEG. And also interictal discharges. So between the seizure episode, the child may have a complete normal EEG. So yeah, as mentioned, we have to correlate with clinical history, and so do not use EEG to exclude epilepsy or in isolation to diagnose epilepsy. So moving on to some cases to look at the etiology. So this child presented at 1.5 months of age. Child had a low-grade fever on admission, so on presentation, had seizures about 3 episodes with head deviation to left, tongue thirsting, tonic posturing of left arm, loss of consciousness, etc. No other localizing symptoms for the focus of infection. Background, this child was born at 36 weeks of gestation, previous cesarean section, so therefore child was born by LSCS delivery. Weight was 2.5 kg, cried soon after birth, had mild jaundice needing phototherapy. Development was appropriate for that age. This is a 4th child of a non-consanguineous relationship. First 2 children were well, but 3rd child died at 3 months of age with what they mentioned is very similar history to this child, seizures looking like this, and was they were kept at home and was brought that, to the local casualty, and they were told that the child had a low glucose at that time. We don't know any more details about it. On examination, here the child was drowsy. Apart from that, there's nothing remarkable for etiology. So we did a baseline bloods. Locally, child had hypoglycemia, had corrected by here. CSF study was unremarkable. Metabolic screen, the basic pH was normal. Lactate was slightly raised. Neurosonogram was normal. EEG was again normal. This was after the child was loaded with levetiracetam on arrival. So EEG after that was normal. And the metabolic results came back as this TMS showed a normal total carotene, low free carotene, and very grossly elevated long chains, such as C14, C14-1, C16, grossly elevated long chain fatty acids, suggesting the possibility of a VLCAD deficiency, very long chain cell dehydrogenase deficiency. So this is in this child we hunted little deeper into metabolic cause, considering the death of the previous sibling. So the child was put on dietary management, which mainly involves special milk with avoiding long chain fatty acids, specially prepared by a company called Pristine from Bangalore. So this was sourced from there. In addition, child was also put on MCT oil for calories. Carnitine was supplemented because carnitine does seem to help in this condition. Also, cardiomyopathy is seen in this condition. So we had an echo done, which showed dilated LV with a mild systolic dysfunction. And child was put on furosemide as on follow-up. And we also gave the child, it's important that in these cases we give an emergency plan, because I will come to that in the following slide. In genetics, we did which confirm this CAD-VL variant, which is which leads to this VLCAD deficiency. So VLCAD is a very long chain acyl-CoA dehydrogenase deficiency. It can have early form and a late form. It can lead to sudden death. So many of the states, at least some of them were that medium chain or long chain acyl-CoA dehydrogenase deficiency. So it can lead to hypoglycemia, cardiomyopathies, cardiac arrhythmias also common in this child. So we generally tell them to avoid fasting, the duration depending on the age of the child. We also give them emergency plan for intercurrent illness. So make sure they feed the child very regularly with dextrose or sugar containing feeds. And to go to the nearest casualty, also gave them a emergency plan which they can take to the nearby hospital, so they also know what they are dealing with, because for their concern was many of the doctors, and I fully agree with that, are not familiar with this condition. So guidance will be very helpful. On follow-up, the child is doing extremely well now, about 18 months of age. The child can have recurrent, they had high CPK, which is almost can be seen in this condition, and the levels are variable. Particularly with infection, other things, the CPK also goes up. So that's about this child. Now moving to the next child. So an 8-year-old child presented with a headache, vomiting, and giddiness to the local hospital from Talasheri. Child had focal seizures with facial twitching. The birth and perinatal history was unremarkable, and normal development, no family history of note. On examination, nothing remarkable. Bloods were also unremarkable. Normal CRP, MRI brain was done. EEG had shown some focal discharges in the right frontotemporal region. Child, I'll come to the MRI. So the child had, you can see in this child had a lesion in the frontal region, around lesion, which can be more seen on this on this picture. So when you see a single lesion like this, then the doubt comes whether this is a neurocysticercosis or whether this is a tuberculoma. That was a differential we thought. So how do you differentiate between them? So this child, going back to the history, is one key which helps. So this child going back, so child was eating pork about 4 or 5 times a year, so not that frequent. So there is a chance that neurocysticercosis can come in. Usually it is seen in non-vegetarians, but of late it's more seen in vegetarian as well. And they found that when the salad, etc., are washed in the rivers with the fecus of the pork, they get contaminated, and so more and more vegetarians also it's seen. And this is more common in North India. We hardly see it South India. So I had only seen 2 cases so far here. So the most often, so what is a MRI differentiation? So neurocysticercosis varies with the stage. So you can see a scolex within the lesion. Sometimes the lesion may be fully calcified. Usually the lesions are near the gray-white matter junction. Tuberculoma, you can see other signs with it. You can have raised ICP, focal neurological efficiency. Lesions are larger, more than 20 millimeter, and the margins can be irregular, lobulated, and it's more often seen in posterior fossa or base of the brain. So we have another child was around December time. So this child has the posterior fossa. You can see the tuberculomas, couple of them here, and marked contrast enhancement. So the child presented with pyrexia of unknown origin, and had tuberculous meningitis, and is doing well on follow-up. So coming to our child, so child had usually we do ophthalmology review to look for any ocular cysticercosis, which is again comparatively the ophthalmologists say they see ocular cysticercosis not that common, but they come across that in our locality. Steroids, we usually give a short course to reduce the edema on the lesion, and again, we start the steroids at the beginning, and then albendazole, the usual 15 milligram per kg per day dose for 7 to 28 days. We gave for 28 days in this child, steroids couple of weeks and tapered. And we did an MRI at 3 months, which is completely, the lesion has resolved, and that's a child who is doing well. The oxetol, child is on oxcarbazepine for seizures, which is usually continued. Child had a couple of seizures after the initial dose, so as the dose is increased now. So at the moment we are continuing on the oxcarbazepine. So moving to the next child. So this is a 7-year-old child. So different etiology. 3 weeks, child had seizure 3 weeks ago. MRI was normal at that stage. EEG was also normal. Child was started on valproate from locally. Child represented and again, this time child presented with seizures and a low-grade fever. CSF was done there, which showed 20 white cell. Child was put on ceftriaxone and also sotalol levetiracetam added in addition, and MRI brain was also done. So in this case, MRI showed some subtle changes. Cortical gyre in the cortical gyre was thickened in the right frontotemporal region. So child had a subtle left hemiparesis. But many of such cases, the MRI can be normal in 50 to 60% of this condition. We'll come to know about what is it as we are moving on. So examination, child had a subtle left hemiparesis without any focal infarct in the MRI. Behavioral changes, mutism, dyskinesias, no meningeal signs. Child was, so we look at you see, here you can see on the right side, this continuous epileptiform discharges. There's focal twitching of the left left fingers and left arm. Just to play the right side, you can see continuous discharges, and this child, so you can see oral dyskinesias, the tongue, so the tongue movements, and also had so this continuous dyskinesias were happening. Child had very refractory seizures. So moving on to the investigations, child had a repeat LP here, which showed white cells of 132, raised protein. Sugar was normal. CSF gram stain and culture were negative. viral PCR was a negative. So most of you would have guessed the diagnosis by now. Child had an anti-NMDR antibody positive in CSF. So ceftriaxone and acyclovir were stopped after a few days. Based on the clinical picture, as soon as after the initial CSF results, by day 3 itself, we started the child on methylprednisolone. Child had methylprednisolone for 5 days, followed by 2 milligram per kg per day of prednisolone maintenance. And also in a couple of days, NMDA receptor also present, so we gave them IVIG as well. I mean, in many cases, you could start, it is advisable to start if it's strongly suspecting to methylprednisolone and IVIG at the same time. So we finish both by 5 days, so 0.4 milligram per kg of IVIG along with methylprednisolone. So we finish both within the 5 days. So the dictum is now to attack them early. The longer the delay may cause more long-term effects. For seizure, the seizure, the child had levetiracetam, phenytoin, and phenobarbital, and the seizure started, and also on oxcarbazepine, the seizure started settling. So child had some improvement, but not that great response. So after about 10 days from waiting for a couple of few days after the IVIG and methylprednisolone, we started on rituximab as well, and had 4 doses weekly. So after that, we could see within a few days, we could see significant improvement in the child, but discharge, child stayed for about 3 to 4 weeks in the hospital, and discharge and follow-up on outpatient. Child was doing, initially the child could not, child was not able to speak, complete mutism. So this is on, so she's, so this is a favorite song. So one of the ways we were trying to assess her improvement was how was she able to sing her favorite song. So she, by a couple of months, she was able to sing a song well, and she was walking fine. The child, so till about 5 months, child was fine, because we monitor the CD19, CD20 levels to see the effect of rituximab. And but unfortunately, at one point she had another. Sometimes we see in this anti-MOG optic neuritis. She had a right optic neuritis, and she was anti-MOG antibody positive as well. At that time, we noted that the CD19 levels had slightly gone up. We had only checked about a month ago. So was at another repeat dose, and the child, another few months down the line, child is doing well. So autoimmune encephalitis is another cause to be another etiology to be considered particularly if you see along with seizures, behavioral concerns, dyskinesias, autonomic dysfunction. So the psychiatric manifestations are common. So recently we had another child. So the third line can be rituximab or cyclophosphamide. We found rituximab slightly better, but then the cost is very high. So a recent child we tried on cyclophosphamide. It takes a little bit longer in cyclophosphamide to see the response. And sometimes the antibody testing may be negative, but clinically, seronegative autoimmune encephalitis is also possible because we only have a panel of 5 or 6 to test. So the clinical picture is favoring we at least go along the methylprednisolone IVIG line, at least to start with. Now, coming to some neonatal cases. The neonatal seizures, again, the classification is a little simpler, again, but similar. It's motor, non-motor, or electrographic seizures are also there because you may not see anything on the EEG, anything on clinically as well. And so it is something we see in neonates. So you look at the causes and again, comorbidities as the child grows. So the causes in neonatal seizures, in majority, what found is hypoxic ischemic encephalopathy in 35 to 45% cases, infarction and hemorrhage in 20 to 30%, brain malformation in 5 to 10%, infection in 5 to 20, metabolic in 7 to 20, and genetic epilepsy syndrome in 6 to 10%, and unknown cause in 10%. So neonates are more susceptible to seizure because of the immature brain. They have a reduced seizure threshold. And hypoxia, ischemia, and hypoglycemia can cause reduced ATP and failure of sodium-potassium pump, affects membrane permeability. So there's an increase in excitatory neurotransmitters, and there is also in neonates a delayed maturation of the inhibitory systems. So again, as mentioned, neonatal seizures are a little tricky to diagnose. In this study published in Archives by Murray et al., only a quarter of the clinical seizures were correctly recognized, and 3/4 of the suspected seizures were actually not electrographic, didn't have any EEG correlate. So, so only 1/3 of the electrographic seizures had clinical features. So, which means EEG or continuous EEG is a need of the hour and more needed in neonatal units. So coming to a case, it's a term normal delivery, child cried soon after birth, day 2 seizures, second child of a consanguineous relationship. History of this child, the previous child had passed away at 18 days of life with refractory seizures, unfortunately. Examination showed myoclonic seizures, encephalopathy. And child initially was put on phenobarbital, levetiracetam, phenytoin. Seizure were not getting controlled. Metabolic possibility was considered, and pyridoxine was started, and the seizures settled within a couple of days of that. And CSF will show the results. So suggestive of pyridoxine-dependent epilepsy, and pheno and phenytoin stopped before discharge. Child was discharged on levetiracetam and pyridoxine, and levetiracetam was also stopped after a few weeks. So child remains on pyridoxine. So this is a child after a few months doing completely fine, and this is a child recently seen like about a couple of weeks ago, about 1.5 years of age, doing completely well. And this is another vitamin treatment treated response thing. You have this alopecia. We have usually they get atopic dermatitis as well, refractory seizure. This is the biotin dependent seizures. So these are like simple vitamins or simple medicine which can treat these seizures. So we have to keep that in consideration when you're dealing with refractory seizures. So just seeing a similar another child. This is a term child, birth weight of 3.1 kg. Antenatal hyperemesis, but fetal movements are normal, difficult vacuum extraction, but cried soon after birth, so they don't think there is any hypoxia as such. No resuscitation needed. First child, non-consanguineous marriage, no family history of note. Day 1 child had a seizure, so CT head was done, which showed from locally, which showed the possibility of cerebral venous sinus thrombosis, and was referred here. Before discharge, before the child was transferred from there, child also had hypocalcemia was noted. Serum calcium was 5.4, so that was correction given locally. And child was for the seizure had received pheno and levetiracetam. So on arrival here, this was the time. This is last time we had floods in August. It's a cold, rainy day. Child traveled all the way from Monarca to here. Child had, by the time child got here, was hypothermic, hypocalcemic, hypocalcemia was persisting, hypoglycemic, and also had some metabolic acidosis. So this is one of the things where the neonatal transport, proper transport would help, which is again another problem we face in our locality, keeping warm and all that other issues. And child had raised lactate. Examination was showed child was encephalopathic, had frequent myoclonic jerks. We'll see a video. Exaggerated statal drive response, had slight hypertonia of all limbs. And this was the, so you can see subtle myoclonic type jerks, quite erratic. So, so child was managed by just warmed up, corrected for hypoglycemia, hypocalcemia, and metabolic acidosis, fluid management, supportive management, etc. Additional dose of phenobarbital levetiracetam also started in pyridoxine because we could see this type of seizures in pyridoxine-dependent epilepsy. By following morning, the seizure had settled and all the basic parameters, just glucose, calcium, etc., had acidosis and all settled. So very aggressive management with help of our neonatal ICU team. MRI brain with MR venogram was done. So again, the conclusion was it was not suggestive of venous sinus thrombosis. Probably the CT picture was related to sluggish flow or slight venous malformation, but nothing remarkable. There were subtle changes in the white matter in the cerebral parenchyma and also in the cerebellum dorsal part. Brainstem dorsal part. So very non-specific changes and a slight glycemic peak of 3.5. So those are suggestion whether this could be non-ketotic hyperglycemia. So we had send the bloods and plasma amino acids and CSF amino acids appropriately. So ammonia was initially high and known as normal. One of the fallacies problem is ammonia is it can be often erroneously raised if you don't do it properly, sent to the lab urgently in ice and ask the lab to process it font. Sometimes an arterial ammonia will be helpful. But even if you're doing venous, if you do sooner and transfer properly, it is that gives a proper value. So we did TMS, GCMS, CSF, and plasma amino acids were normal. So had some derange LFT and RFT values, possibly related to all the journey and difficulties, seizures, etc. Seizures settled. EEG following day was normal. Clinically improved. Child was discharged on levetiracetam and pyridoxine. Other AEDs were stopped. And calcium supplements and D3. So maternal vitamin D was checked, which was also low. So we are planning to work for additional causes for hypocalcemia later on based on how things go on, follow. So we thought the etiology was possibly likely secondary to hypocalcemia and possibly a degree of hypoxia at birth, but non-ketotic hypoglycemia is considered, but felt to be less likely considering the improvement of the child. So the story didn't end there. At 2 months of age, child presented locally with a febrile illness. Seizures again restarted. Child had a facial twitching, right hand focal onset, becoming bilateral or secondary generalized, as we said. Initially, it settled with lorazepam. Child was given ceftriaxone, had mild respiratory symptoms, but nothing major there. Then again, the history was the family had stopped the pyridoxine or the B-long, the trade name, couple of weeks ago because the child didn't like the taste, and that is one of the problems with this tablet. We don't have a liquid preparation. So again, child had the increased dose of levetiracetam, eptoin, antibiotics. Pyridoxine was restarted. Supportive management. CSF was not suggestive infection. This time we sent the CSF pepicolic acid, which was raised in this child, suggesting that biochemically this is likely pyridoxine-dependent epilepsy. Genetic study was suggested, but due to cost haven't been done yet. Child is doing remarkably well on follow-up. So this was the child when the child presented 2 months. So you can see a focal type of seizure with the right arm jerking. Unfortunately, the videos, because of the YouTube thing, we had to mask the face, so which is not an ideal for this seizure type seizure presentation, or to demonstrate seizures, because a lot of things to see on the face and eyes are important. The child is doing well now, few months down the line, making developmental progress appropriate for age development, and no seizures, just on pyridoxine and a dose of. We sometimes add folinic acid as well, because the pathways are interconnected in this child. Now, so neonatal seizures, once you find it refractory to anti-epileptic drugs, then if there is segmental erratic myoclonus, as we was shown in our case, or apneic seizures, please consider giving a pyridoxine trial. So usually dose is 100 to 200 milligrams slow IV. It has to be, it is helpful if you have an EEG along with it, so that you can see a sudden response to the EEG normalizing after pyridoxine. And but there's a risk of apnea, so child has to be in the neonatal unit. Some in places with limited facilities, oral loading can be tried with 30 to 50 mg per kg per day of oral pyridoxine, and you may see a response in a couple of days. And pyridoxal phosphate deficiency trial can also be given. Sometimes the pathway pyridoxine itself won't cover, so that is about 30 to 50 mg per kg per day, available plus tetrafol plus folinic acid. In this, we also add folinic acid and biotin as well in refractory seizures. Now, yeah, moving on to another child. So this child was referred on day 34, right soon after birth. Day 3, myoclonic seizures. Was on the usual phenobarbital, levetiracetam, fosolin, not controlled, added pyridoxine, but this time had a good response and discharged an oral pyridoxine. But they had from locally had done an extensive metabolic investigations, including the CS of pipicolic acid and urine ASA for pyridoxine, and this all come back as negative, so it was stopped. So this was the seizures of the child. This is quite a focal jerking of left upper limb and left lower limb. So after stopping the pyridoxine and biotin, child had a recurrence of seizures, multifocal myoclonic jerks, again refractory seizures. Went back on phenobarb. Child was on oral of these drugs, went back on IV of this midazolam infusion, referred here day 34. Again, we restarted on pyridoxine and pyridoxal phosphate as well on this child, considering that the seizure had come after stopping pyridoxine, because pyridoxine is a vitamin which is helpful in multiple pathways control epilepsy. So even if it is not the typical anticotin deficiency where you get the pyridoxine dependent epilepsy, you may have some benefit. So we continued. Seizures did settle, but unfortunately, as we were trying to change to oral, it restarted. But we got some control, added some clonazepam, other drugs, and the vitamin cocktail had some control of seizures and was referred back to the referring hospital. And child had a genetic clinical exome sent. So this time we had this casein Q2, that is one of the cause of early infantile epileptic encephalopathy. So yeah, so that's one of the things you find. So this is a genetic epilepsy. Unfortunately, the sodium channel blockers help in this condition. Some other, but there are seizures are usually refractory and difficult to control. The child had on and off seizures, but again now lost to follow-up. I think they had gone to NIMHANS and probably heard they probably had gone to some Ayurvedic treatment and other things. We lost touch. So this another child, day 47, had an eye deviation to left and left arm posting, so focal seizure. Was admitted locally, and on day 30 was readmitted, had multiple seizures, IV Levipil, phenobarbital, tafricium, and pyridoxine. So on video, the child had also seizure from the right hand posting, so not just the left, the right hand onset was also there. So again, this had as a term child, weight were 2.94, no perinatal concerns, no antenatal concerns. First child, non-consanguineous, family history of note. Examination, child had focal motor seizure with bilateral onset. Again, we were focusing on etiology and particularly for treatable causes. MRI ruled out a structural pathology. Baseline bloods were normal. Video EEG was done, showed frequent discharges from the left side, left frontal temporal occipital region. Again, some independent discharge on the right side as well. The basic metabolic tests, as you can see on the screen, were normal. So you can see continuous epileptiform discharges on the right side. The left is more or less suppressed, but again, we couldn't see much of clinical changes with many of them. So this is why we say that in younger age, you may not see anything clinically despite having so much of epileptiform, that this sharp waves looking like an electrographic seizure on EEG. Child had continuous background activity on this side and sometimes on the left side. So CSF, again, the metabolic, so this is a normal amino acid, uric acid, biotinase, they were all normal. CSF white cell was normal. Glucose, plasma glucose ratio, which we, after a fasting protocol, we do for GLUT1, transporter deficiency, that was also normal. CSF amino acids, lipoic acids, normal. The clinically, so we were suspecting migrating partial seizures of infancy. So again, so I'm going a little faster, I know, as the time is ticking. So child had difficult to control seizures. So we added oxcarbazepine as well, considering the focal onset of seizures. Vitamin cocktail was there, doses were optimized, but we were somehow able to manage to control the seizures by discharge, and child had few days seizure-free, change to oral and discharge. And in this child, we had this genetic study which showed KCNT1 mutation, which is it's one of those mutations seen in early infantile epileptic encephalopathy or migrating focal seizures or partial seizures of infancy, where you can have seizure from onset on both sides with the EEG showing epileptiform discharges from both sides. Again, in this epilepsy, there is this tried, quinidine is one of the drugs which has been tried with some benefit, although it's not like fully proven, but we've seen some benefit in some kids, again, very refractory epilepsy. So now just coming to etiology, it's important that if you have an early infantile epileptic encephalopathy, if the MRI is normal, no structural pathology, basic metabolic screen is normal, then consider the possibility of genetic epileptic encephalopathy. Recurrence is usually low because they are single gene disorders. Again, these are, probably we'll skip that. These are the other causes. So the epileptic, usual epilepsy syndrome has on hyperventilation getting the absence seizure. This is a 6-year-old with a typical childhood absence epilepsy. Again, I fully appreciate the masking of the face doesn't help. Another epilepsy, this child with a herpes encephalitis in the neonatal period, in about 4 months age, presents with spasms, flexor spasms, infantile spasm, developmental regression, reduced visual attention, etc. So this is West syndrome. So these are the usual epilepsy syndromes, which will come to that in the coming slides, which may come across. There are other common ones which will come as we go along. So now moving to the next part, the time is a little tight. So once you have this seizure, we try to formulate this describe approach, which is the description of the event, paroxysmal event we call it epileptic or non-epileptic. Whether it's an epileptic or is it a non-epileptic. And if it is epileptic, we try to see what is the seizure type. in this. And if you find the seizure type, next line is there an identifiable epilepsy syndrome, such as we mentioned earlier? Can we look for a cause? So C stands for cause. And R, the RIB in describe is important. What are the relevant impairment, behavioral, emotional issues, educational issues? So these things are often missed. So if you put this acronym help us to cover all the parts of a holistic management of the child. So our aim of epilepsy treatment is to achieve seizure freedom with minimizing the adverse drug effects, reduce morbidity and mortality, improve quality of life, minimize adverse physical, cognitive, or behavioral effects of AD treatment. So the correct dose is the lowest one that can achieve seizure freedom without adverse effects. So it is possible to achieve that in you choose any drug in 60 to 70% patient with a single appropriately chosen AEDs, we can get 60 to 70% remission. But addition of a second dose, if needed, may add only another 13%, and a third drug will add only 1 or 2% to overall treatment. So our aim is to try to control with one drug, but it's important that we choose the most appropriate drug, and when we look at some of the steps for that. So initially we had very few AEDs. So in 1860 we had bromide, then the phenobarbital, phenytoin. By 1980s we had about 7 or 8. But in the late 80s to 2000, now we have another 10, 15. So we have a lot of newer AEDs now. Now the standard AEDs are the phenytoin, phenobarb, carbamazepine, valproate, and the newer ones are as listed on the screen. So the mechanism of action of them is different. We have the sodium channel blockers, we have the calcium channel blockers, the levetiracetam which acts at synaptic vesicle 2, then potassium channel activation reticabin, glutamate, potentiation of GABA activity, which is this barbiturate, topiramate, valproate, etc. We won't go into details for want of time. So again, this table gives you the different mechanism of action of different drugs, but here you can see some of the drugs such as valproate acts at multiple levels. So voltage get at sodium channels, as an action in calcium channels, potentiate inhibitory transmission, excitatory transmission. So these are drugs which acts at multiple sites and therefore called broad spectrum. So this topiramate is also there. We can see it's in 3 or 4 columns. But drugs like oxcarb is more with the focal seizures of carbamazepine. So it's a narrow spectrum drug. So what we call broad spectrum is one that has multiple mechanism of action, usually a multiple, except for levetiracetam, which is a novel mechanism. It again comes in the broad spectrum. It's effective against wide range of seizure types, such as focal, generalized, myoclonic, etc. Some of the examples are, as we covered, valproate, benzodiazepines, lamotrigine, levetiracetam, topiramate, zonisamide, phenobarb. Now, narrow spectrum is effective only against a restricted range of seizure type in epilepsy, and it may exacerbate seizures if used inappropriately. So, drugs like phenytoin, carbamazepine, oxcarb, bigabatin, etc. And it's a busy slide, but it is important that as a pediatrician, we understand the important side effects, common side effects of the drugs we are using, and as you know, all of them will cause some somnolence and fatigue, etc. But particularly to note is with phenytoin with the gum hyperplasia and things. So particularly in a female child, it is it's generally not, or even in a male, not used on long term because of the disfiguring effects. And ethosuximide is used in absence epilepsy. Again, not much of an issue. Carbamazepine can cause diplopia, dizziness, hyponatremia, which is little, again, oxcarb can cause similar things, but also to note the Stephen Johnson. So the rash things that important, we advise the child on carbamazepine, or for that matter, lamotrigine as well, or other drugs as well. That especially important to say that if they have a rash, the child should see a local pediatrician or neurologist before continuing on the dose. So it is very important that if they continue the drugs, then they can go to full-blown Stephen Johnson syndrome and have claim lives. So again, topiramate again causes somnolence. There is a mental slowing, speech disturbance, etc. Levetiracetam can cause some mood swings and irritability, etc. So one thing to watch for. Otherwise, it's a reasonably good drug. No, this is so it's not come out properly. But the step one of choosing the drug is it an epileptic seizure? Is the first question. And what is a seizure type? What is a seizure type? Is focal, generalized, or both, or unclassified? Then what is the etiology? Can we look at an etiology? So the fourth is this an epilepsy syndrome? That's the fourth step of choosing the right anti-epileptic drugs. And the next step is looking at the efficacy of the drug and tolerability of the drug. Efficacy means how effective is the drug is controlling this seizure type. And the second part of is tolerable. If it is effective, is it a tolerable drug? And that's important to see the patient profile as well. So we have mentioned about the epilepsy syndrome, and I think many of you are familiar. It's a clinical, electroclinical pattern of clinical findings and investigations, which have different etiologies based on the clinical picture, EEG, and age, etc. We can classify them into an epileptic syndrome. The reason it helps is it helps to choose the appropriate anti-epileptic drug, because we know the first choice, second choice for this. And it also, we know about the comorbidities in this epilepsy syndrome, and we can also guide prognosis. So examples of that will be West syndrome, Lennox-Gastaut, Dravet's, childhood absence epilepsy, juvenile myoclonic epilepsy, benign epilepsy with centrotemporal spikes. These are some of the common ones we see. We won't go into the details. So I think this we have seen this another epileptic child with infantile spasm. Child had a listen carefully. So treatment in infantile spasm is steroids, either ACTH, use oral prednisolone, and vigabatrin, particularly in tuberous sclerosis child. Vigabatrin is the first choice. And in the general measure, the drugs to avoid. So valproate is to be used with some caution, in particularly in infants when we don't know the underlying etiology, because in metabolic or mitochondrial disorder, it could cause hepatic derangement and problems. So it's so as a baseline, it may be helpful to at least do a lactate level, ammonia level, and SCPT before we start the drug, and use with caution in younger ones. Dravet syndrome, it's a sodium channel blocker drugs are avoided, such as lamotrigine, phenytoin, and carbamazepine. Absent seizures, again, avoid carbamazepine and phenytoin, because, and again, with myoclonic seizures, these drugs can exacerbate them. If you're planning for ketogenic diet, then topiramate and zonisamide not used commonly, because together with, they can increase the risk of nephrolithiasis. And yeah, precision medicine, sorry, so precision medicine is where, coming to the last part, where how the technology has actually helped us to do a more targeted therapy. This is a diagram from the NHS in 2015. So Bruce Keogh had a paper where he put this type where we wanted to move from the one-size-fits-all approach to more targeted intervention. So, where we use the use of technology such as the genetic tests and things to predict the disease. So to predict the disease, targeted prevention, early identification of disease, precise diagnosis, targeted interventions, improve. So it may help improve the outcomes and avoid the unwanted side effects and adverse effects of it. This is more used in oncology. They already use it quite a lot in practice. So in epileptic encephalopathies, we have so many mutations which we have found over the years. This slide is not very clear, but as you can see over the years, we're finding more and more genes involved in it. So infantile spasm has about a group of 40% cases, we still can't find a diagnosis, but a group of genes which are which can cause infantile spasms. We do look for child with infantile spasms. So we look for treatable causes if we don't have a structural reason to account for, and a metabolic screen. Genetic tests are done if it's affordable, and for the patient. And other things like myoclonic and cephalic, they all have some genetic etiology, just to show you how the technology has changed over time. And how these targeted things can help. So in this child who presented with focal onset, so infant with focal seizures, hemiclonic seizures, presenting status, completely normal child in the infancy. And gradually they start getting more and more myoclonic seizures and other seizure types. So this is a picture what they are very temperature sensitive with vaccinations and hot water sometimes can trigger that. So this is a typical Dravet syndrome. We see this SCN1A mutation. So in this, if you have a diagnosis, then it is possible that we can advise the family accordingly. We can choose the right drugs. So the treatment of choice is valproate, clobazam, stiripentol is commonly used but not available in India. Topiramate is the next line. But it's particularly important that we avoid the sodium channel blockers, as mentioned earlier. So in these children, after the, if you know the diagnosis, suspecting that after the after the lorazepam as a status protocol, we would rather go to phenobarb as the next line and avoid phenytoin. So now a child, they're again also prone to infections. So that child again unfortunately had a severe ARDS post H1N1 pneumonia, and was again felt not to be a candidate for ECMO based on this underlying pathology, and unfortunately passed away. So this is another slide which shows how the genetics and have helped in some situations. So these are conditions. So we have conditions like SCN8A, such as in our case, the KCNQ2, as we mentioned, SCN1A. These are some situations where a sodium channel blocker is helpful. So normally in infancy, we are a little cautious about using abamcipin as that group, but because we don't know what the seizure type is not very clear, and even we won't get the typical generalized tonic-clonic seizures because as the brain matures, the seizure type and the EEG evolves. So in this, if you know genetic pathology, then now we know that sodium channel blockers are helpful. So many of the cases where we don't, if it looks like a genetic, then we go on that line, and in many of the children we have seen some response with that. So these are the targeted therapies. Again, it's coming under the big umbrella of the precision medicine. So we have this mutation pyridoxine, SLC2A1 ketogenic diet, and then the nicotine as KCNT1 is the one we mentioned. Quinidine is helpful. Then KCNA2, 4-amino pyridine, KCNQ2, retigabin is helpful. Memantidine in green 2A, green 2B. So some other drugs are not available, but as mentioned, sodium channel blockers are helpful in this condition. And of particular mention where the precision medicine helps is in a condition tuberous sclerosis, where we have the mTOR inhibitors such as everolimus, sirolimus. It helps to reduce not only the seizures but also the growth of SEGAs and other complications related to tuberous sclerosis. And in this condition, even vigabatrin, mostly all of these drugs are anti-epileptic drugs, are more like a prophylactic drugs. They don't cure the underlying condition. They kind of suppress epileptic activity. But vigabatrin in tuberous sclerosis is found to also help in so some of the European countries even use vigabatrin quite early on before getting into the full-blown epileptic spasms. Now, just a word on other modalities. We have a ketogenic diet, epilepsy surgery, neuromodulation. So some of you are not familiar with ketogenic diets, a high-fat, low-carbohydrate with adequate protein diet. It does help with more than 50% seizure reduction in 38 to 60%. And in 30%, it may help in more than 90% cases. It's particularly effective in GLUT1, which is a glucose transporter deficiency, Dravet, myoclonic atonic epilepsy, but it's contraindicated in fatty acid oxidation disorders, carnitine deficiency and pyruvate carboxylase deficiency. Different types are there: classical diet, modified kits, MCT diet, low glycemic index diet, etc. Epilepsy surgery, we won't go into detail, but it is, if you have a lesion structural lesions, then consider epilepsy surgery may be helpful in those children. And sometimes you may not find a structural lesion in a 1.5 Tesla MRI, so 3 Tesla MRI will be helpful. So they need to have video EEG monitoring to find the epileptogenic zone and see if we can take off that area without causing any functional deficit or minimal functional deficits in the child. Again, it's extremely important that we look at the child in a holistic way, educate the child and the family about the condition and the compliance, and this is very important. Despite being so much advocating about the importance of medication, we still see that parents often we follow them. Recently, we had a child suspected autoimmune. They went home, and then I think they're going for alternative religious treatment and things. So this is despite all the importance, it is difficult. So it is very important that we go through in at length and try to acknowledge the concern. Managing comorbidities, education is also important. Seizure first aid is extremely important. That as a pediatrician, we tell them what everybody knows, but take a few minutes to explain what they should. I have a video of that where a child mother had given a large seizure for a metal. He couldn't find key at that time. The problem here is they go for finding these things rather than putting the child in the recovery position and other things which are more procedures are more important than that. So it is important that we tell them. Also, in terms of lifestyle modifications, we tell them about precautions with height, swimming, this thing with heat, stove near the stove, etc. But not restriction. They should be able to take part in any activity like some with supervision though. Sleep and missing drugs are important. So coming to the last slide, seizure is a common presentation. There is a diversity of etiology underlying it. So just as a symptom or a sign and see if you are not missing anything. Dig harder if needed, particularly in when there's a history of previous sibling death or anything metabolics. Look harder, but even otherwise we should think about it as we had shown, as I had shown in our cases. And now, importantly, not all shaking is epileptic seizure. ECG is must in a syncope, particularly with tonic movements. And there is pitfall in EEG. Choose appropriate EEG. We covered targeted therapy, impact on the child, teaching first aid. There we should help dispel myths and spread awareness. And I would like to thank our alma mater, Medical College, Institute of Maternal Health, my teachers, also our hospital, KIMS, Al-Shifa and Talasheri, the corporate hospital where I visit, and which have helped me to for the cases and the experience. And I also acknowledge the training which I had the good fortune to work on the centers. It's a Great Ormond Street Hospital in London, Southampton University Hospital, Leeds Children's Hospital, Young Epilepsy, Hammersmith Hospital, where I had good experience in neonatal neurology, and the University Hospital of Cleveland, where I did my neurophysiology training, and a brief stint at SickKids Toronto. So acknowledge all the all was possible from the spark I had from IMCH. And many thanks to all the patients and parents and all the supporting staff and consultants, colleagues, and all the other doctors and pediatricians supporting. And I thank you very much for your time and attention, and time for questions. Thank you. Sorry, it was a little long. Hope you could bear with that.
Okay, I think that was an exhaustive talk by Rajesh, and I think he has covered from the very basic to the newer thing. Nihas, shall we go for a discussion?
Kunju sir, if any queries, they can send the message to the chat box. I will read that question.
Okay, there are a few questions
If anybody,
there.
if anybody is having any clarification, any point to raise or highlight, please send the message to the chat box.
There are two
I will-
questions there. Rajesh can answer them.
I will read.
Okay, I'll find.
Already there is a question. I will read that.
Shall I stop share or
Yes, sir.
stop the share? Maybe. Okay, I can see the question now. Shall I read the question and answer?
Yeah.
Yes, yes.
Patient is on Valparin for
Okay.
more than 1 year, now under control, but she is having repeated episodes of severe abdominal pain for few days. Should Valparin be changed? Other causes to be ruled out. Other causes already ruled out.
Okay, so in a child on Valparin, one of the things, dangers when hepatitis is one thing, but acute pancreatitis can also be seen. So something to look for the amylase levels. If it is already done, it's fine. But I have just had one child last week who was on Valparin, started from Sri Chitra as a benign epilepsy syndrome, but other drugs had all failed. Child had recurrent seizures. But child was having abdominal GI type symptoms for over about 2 weeks. It started after the Valparin, and child had ongoing symptoms, had OGD, which was normal. And then at last, recently, they did a amylase, which was quite raised with the ultrasound suggestive pancreatitis. So we had to urgently, acutely admit the child, stop the Valparin, and switch to another AED. So I think it's probably worth looking at in detail.
Sir, anything to add on that?
Yes, actually, the Rajesh suggestion of acute the pancreatitis secondary to Valparin or sodium valproate is a very good thing, because many times it is missed also. And at the question, I think the person who has asked the question, Dr. Mahima, I think she would have thought abdominal pain as a seizure, because here we must ask the seizure pattern.
Sir, it is not Mahima, it is me, Dr. Harikumar. Mahima is my daughter.
Okay. Because I did not see the. Actually,
Yes,
I have recognized you from the video, but I was just looking at the chat box. That is why. Harimar, I am happy that you are always there and attending the webinars. This is very good. Anyway, here I think you are thinking that abdominal pain is a seizure, isn't it?
No, sir. I think it is a side effect from Valparin, because that child is having treatment from CMC Vellore, and seizure is well controlled. But after 1 year of treatment, now she is no. I have that a pediatric surgeon seen, and gastroenterologist also seen. Everything other causes are rolled out. So I thought it is maybe due to Valparin.
But in that case, if the amylase was normal and child was on it for long, I think it may not be related to that. We may have to look for other causes. That may be the reason. And since if it was only 1 year, and suppose the child had only 1 or 2 seizures earlier, after even we can think of tapering and stopping also, because if child had only 1 or 2 seizures, it was well controlled with single drug. In that case, there is no need for continuing for even more than 1 year.
Yeah, that's true. If you can stop it, that will
There was
be.
one more question before that. Rajesh, do you want to answer
Pyridoxal
that?
phosphate.
Yes.
About the pyridoxal phosphate availability. Tell, sir.
Pyridoxal phosphate is available as it's called tetrafol plus. It has pyridoxal phosphate, B6 also, B12, B6 also there. So it is combined thing, tetrafol plus.
No, because they were asking about tetrafol plus has it, but it has pyridoxal phosphate, isn't it? Okay.
Question.
It has a tablet form. Very good. That is available. Yes. Very good. Tetrafol plus.
Yeah.
But the pyridoxine is available as is not as a separate injection, but we have to use the Neurobion Fort. Neurobion Fort has 1 ml has 50 milligram. So if you want 100 milligram, then 2 ml has to be given. This pyridoxal, as suggested by Rajesh, Tetrafol Plus, that is by Sun Pharma. It is available.
Ranjit, please unmute our State Secretary, Dr. Bala, for comments.
Sir,
Bala.
congratulations to Dr. Rajesh for a very informative talk. It was very elaborate also. As Sir has said in the beginning, because of his systematic approach, only the neurology chapter got the award at national level last year. And one request to IAP Kozhikode is that it is high time we should discuss more of monsoon diseases. I told the IAP Trivandrum also. I think Trivandrum and Kozhikode should go together and discuss. Most of our monsoon is coming. We'll have a lot of problems in dealing with dengue, lepto cases. So I think in your webinar there is no topic on monsoon diseases. So, but if you can include that also, it will be good. Thank you. Thank you.
Thank you, Dr. Bala. Your points are well taken. Now, if anybody want to raise a comment or highlight some points, CK sir, please raise your hand. Ranjit, please unmute CK sir.
Yes, Rajesh, that is a very nice presentation.
Thank you, sir.
Touched upon the intricacies of managing a neonatal seizure and the recent investigative modalities available, especially on lines and the neuroimaging and the EEGs. You have mentioned one patient with, cardiomegaly and the seizures, and we have come across syndrome of hypocalcemia and cardiomyopathy. This can be likely be missed. We have missed one patient, but subsequent pregnancy they came and we could pick them up in the very beginning, and I think this was picked up even reported in Indian Pediatrics. This is one point. Then, regarding duration of treatment, you should emphasize a little more because so many younger pediatricians are listening to your talk. How long? How far? And of course, we will enumerate the problems that you encountered. That is excellent. And in between, there are neurologists, especially adult neurologists, who believe in add-on drugs when it is not fully controlled. And it's a very difficult problem. I think Dr. Gunju comment on this issue. This is very important because, and rightly the duration of treatment, then the whole family is involved in managing this patient. And we know that there's a stigma of epilepsy in every family. So they would like to conceal the information from the society as well as from some of the doctors they treat. And one danger of this tendency is when they come and admitted for various other conditions, they don't divulge drugs that is given, the problem that has been explained, because most of the pediatricians will be antihistamines. And I don't think you will recommend to give antihistamines for every patient who is on seizures. Anyway, thanks. Please continue this type of management and presentation. Thank you once again.
Thank you, sir, for the comments. Didn't go into the details about how long because it was already long, the presentation, but generally we go for 2 years, like usually 2 years from the last seizure. But depending on the epilepsy syndrome, some like juvenile myoclonic, it's much, some of them need lifelong. So it may change. And again, if the symptomatic seizure, it is usually much shorter once the symptom, the etiology is controlled.
Rajesh, thank you. We are planning to close the session by 9:30. So if anybody else want to raise or highlight a point, please raise your hand. Dr. Ranjit will unmute you. Ajit and Shaji sir wants to make a comment. Ranjit, please unmute them.
I'm just reminded of my college days when it was a seizure or no seizure. We had only phenobarbital with us. There was no EEG, no CT, no MRI, no exome sequencing, nothing of that sort. From there, we have come a long way. I'm happy that Ranjit has given a very good talk on the various aspects of it. A few things which I would like to comment is the general pediatrician who is dealing with seizure should be familiar with the side effects of the drugs that he is using. He need not know everything, all the different drugs. There are so many drugs in the market there, and many new drugs are coming in also. So he must be familiar with a few drugs that he is commonly using, and then stick on with that. If there is a need to increase or add on something which he's not familiar with, I think it will always be better to send them to a pediatric neurologist or get a second opinion. And if the seizures are not getting controlled, just rethink about your diagnosis. Is it a seizure? As Ranjit was initially saying, about 30% of them are not seizures. So is a seizure is something which you would always think about when your seizures are not getting controlled. And of course, you have a lot of metabolic conditions also, which is also keep in your mind. So congrats, Ranjit, for highlighting on those aspects. And I'm sure that we will, together as all the pediatricians, be able to improve upon the life of these children. And another aspect is to convince the parents about the duration of the treatment, because the moment they find within a month's time if there's no seizure, many of them stop the drug. So this is very bad or very sad because they are not convinced about it. Counseling there again is very important. So also a regular follow-up. You say that the child may have to be taken for, the drug may have to be taken for 2 years, and they come back only after 2 years saying, so these are certain things which you got to highlight. Thank you very much.
That was a very useful information, the importance of counseling. And regarding the adverse effects also, especially in the case of carbamazepine, Krishnamar may remember we had a very bad experience because of the lack of time. I invite Dr. Ajit for his comments.
Thank you, Dr. Rajesh, for the excellent talk. I'm very happy to see Kunju sir, my teacher here, mine and Mohandas team. We were very fortunate to be under him, and we have seen a lot of pediatric neurology cases. And my question to Dr. Rajesh is, how often do you do the how do you measure the do you always do a blood level of anti-epileptic drugs, or is there a need? If they are refractory, when do you do it, or what's the protocol for that? So drug level monitoring of anti-epileptic drug.
It's a very good question. Usually there is no regular protocol for doing levels, so it is done in practice. Sometimes you end up doing like drugs like phenytoin, which has very erratic absorption and things. But as of general, the drug levels are hardly used in practice, and particularly it may be helpful in patients where we suspect the compliance. Then because they say they have given the drug, but then if the child comes in status and things, so those may be helpful, but not a usual practice to do. I don't do that regularly.
Kunju sir, we conclude. Now I think no more questions. With your permission, I invite Dr. Nihas for a vote of thanks. Thank you, Kunju sir, for being with us for this program. Okay, Nihas.
Thank you, Rajesh sir, for that nice and elaborative talk on neurology. Again, thanks, Kunju sir, for accepting our invite and being here. Bala sir and all the state leaders, Venkateshwar sir who joined us. Thank you very much for joining us, and all of us, so all of the members who joined us for this meeting through Zoom and through YouTube. I think now YouTube is getting more popular. People are watching more on YouTube than on Zoom,
rather than directly participating.
And thank you all for joining us. And we'll continue with our meetings, programs next week also. So on 1st June, we are coming back with a panel discussion on neonatology, that is office practice in neonatology, moderated by Dr. Anand of Prims Hospital. So invite all for that meeting. Thank you all for today. Good night.
Thank you, IAP.
Thank you, Dr. Rajesh. Thank you, Kunju sir. Thank you all.
Okay, thank you. Thank you. Thank you.
Thank you,
Okay,
Kunal
bye.
sir.
Bye.
Bye, bye, bye.
Nihas.
Bala, thank you.
Thanks.
Bala, ഏകദേശം
Yes, sir.
എല്ലാ മീറ്റിംഗിലും ബാല ഉണ്ടാവാറുണ്ട്. Thank you.
Yes, sir. Yes. Yes, sir.
നിഹാസ് എത്ര പേര് യൂട്യൂബിൽ വാച്ച് ചെയ്തു?
40.
40 ഉണ്ടായിരുന്നു.
അതായത് പാർട്ടിസിപ്പന്റ് ലിസ്റ്റ് മറ്റേ ഒരു 60 എന്നൊക്കെ കാണിക്കുമ്പോഴും നമ്മുടെ വീഡിയോസ് 80ന്റെ മേലെ കാണുന്നുണ്ടായിരുന്നു. യൂട്യൂബിൽ കുറെ ആളുകളുണ്ട്. യൂട്യൂബും നമുക്ക് കാണാൻ പറ്റും അല്ലെ?
സൂമിൽ കയറണ്ട, അങ്ങനെ ഒരു ഇത് വരുന്നുണ്ട്. സൂമിൽ കയറാതെ യൂട്യൂബിൽ കയറാം.
അതെ, ജസ്റ്റ് യൂട്യൂബ് മാത്രം കണ്ടിരുന്ന പോയോ? മീൻസ് വേറെ ചോദിക്കും ആരെ കാണണം നമുക്ക് മനസ്സിലാവില്ല. ക്വസ്റ്റ്യൻസും ചോദിക്കണ്ട, കമന്റ്സും പറയണ്ട.
കമന്റ് പറയാൻ പറയത്തില്ല,
അതെ, കമന്റ് പറയാൻ പറയത്തില്ല.
ഇന്ന് സാറ് നമ്മള് മറ്റേ ഓതന്റിക്കേറ്റഡ് യൂസേഴ്സ് ആണ് ലോഗിൻ എന്നുള്ള രീതിയിൽ വന്നത്. അതുകൊണ്ട് കുറെ ഫോണുകളും മറ്റേതൊക്കെ ഒഴിവായിരുന്നു.
യൂട്യൂബിൽ ചാറ്റ് സെക്ഷൻ ഉണ്ടല്ലോ, യു ക്യാൻ ചാറ്റ് ഫ്രം യൂട്യൂബ് ഓൾസോ.
പക്ഷെ നമ്മള് വ്യൂ നോക്കണത് അല്ലെങ്കിൽ
അല്ല, നമ്മുടെ നാഷണൽ വെബിനാറിൽ അങ്ങനെ ഉണ്ട്. നാഷണൽ വെബിനാറിൽ അതിന്റെ സൈഡിൽ ഒരു ചാറ്റ് സെക്ഷൻ ഉണ്ട്.
പക്ഷെ നമ്മളത് ഇപ്പൊ ഈ ടോക്കിൽ നമ്മൾ ശ്രദ്ധിക്കുന്നില്ല, നോക്കാറില്ല. അതാണ് പ്രശ്നം.
നോക്കിയാലും യൂട്യൂബിൽ കയറണം.
താങ്ക് യു രഞ്ജിത്ത്. നിഹാസ് ഇന്നും മറന്നു തന്നെ.
Okay, good night.
Good night. Good night. Good night.
Good night, sir. Good night. രഞ്ജിത്തെ, നീ എന്റെ മീറ്റിംഗ് ക്ലോസ് ചെയ്തോ?
ഞാൻ ക്ലോസ് ചെയ്യാം.
എന്റെ
മറ്റേത് ഔട്ടായി പോയിരിക്കുന്നു.
ഔട്ടായി പോയിട്ടുണ്ട്. അതാ.
ഓക്കെ, ശരി.